Hello, my name is Zane Johnson, and I'd like to walk through the design process for a pediatric supracondylar humerus fracture wire navigation simulator. The three co-authors involved in this development are Dr. Gab W. Thomas, Dr. Stephen Long, and Dr. Donald D. Anderson. The American Board of Orthopedic Surgery mandates that all orthopedic residents receive laboratory-based skills training during their first year of residency. Surgical simulation is an excellent way to achieve this mandate. However, there are very few commercially available options. To meet this need, our lab has developed a suite of surgical simulators. One of the areas we chose to focus in is the process of wire navigation, which involves using a drill to place long, semi-flexible wires into precise locations within the bone using fluoroscopy, a low-dose form of X-ray images for guidance. Our simulators replicate this procedure by providing a physical bone and soft tissue model that surgeons drill into with a real surgical drill and wire. Automated user performance analysis and simulated fluoroscopic images are provided by tracking the surgical wire with stereo position cameras to create a virtual surgical theater. The simulator that I will be covering today trains and assesses the skill of wire navigation in a supracondylar humerus fracture, one of the most common fractures in pediatric patients. It involves placing 3 wires in the distal portion of the humerus. I will cover my design constraints, design process, and then a new technique I developed to validate the mechanical rigidity and repeatability of this simulation platform. There were several considerations that went into this design. First, the humerus must be placed in space so that the wires being drilled into can be seen by the cameras in the working envelope. The working envelope is defined by the intersection of the field of view of the 2 cameras, shown by 2 yellow cones in this image of the simulator. The design must also feature the same mass bottom as the hip navigation simulator. With this design feature, only the mass is changed out when switching between modules. For efficiency, it would be ideal to use only the distal portion of the humerus where the surgeons drill as a consumable. This keeps the cost per simulation down. Finally, the relative motion between the bone and the simulator must be minimized. To maintain calibration of the simulator, there needs to be a richer connection between the cameras in the base to the anatomy of the interest on top of the mast. It also needs to be repeatable for swapping out the bone between simulations. The accuracy of the simulator needs to be under 1 millimeter, so we deemed error of placement greater than half a millimeter unacceptable. A design was created with all these considerations in mind and is shown in this image. The full humerus is shown for reference. It satisfies several of the requirements. The first is that the wires will be visible by the cameras. Fluoroscopic images from real cases were used to determine the ideal position of the bone so that the wires would be in the working envelope of the simulator. Next is the mast. This design features the exact same mast as the previous simulator, which makes changing procedures easy using the same base. This contributes to its ease of use as well. Another feature that makes it easy to use is the replaceable distal humerus. With this design, after each use, the distal humerus must be removed from the mount by loosening the single set screw and removing it. The set screw is placed in the mount to push the bone inside the holder up into a negative shape of its surface to increase friction to prevent rotational motion. There is also minimal material being used. The surrogate bone part is only the distal humerus instead of the entire humerus bone. The last consideration to check is the relative motion in the mount. As mentioned earlier, this is critical to the function of the simulator, so an experiment was run to test this. 2 main parts of the experiment were testing the rotational stability and repeatability of placement. The rotational motion experiment consisted of placing a bone in the mount and 3D laser scanning it. A clockwise torque was then applied to the bone and scanned again. Counterclockwise torque was applied and the assembly was scanned a final time. This process was repeated with a second bone. A deviation analysis was then conducted comparing the change in the surfaces of the 6 different bones in 1-to-1 comparisons of each other. The repeatability experiment was conducted similarly by placing a bone, scanning it, removing it, replacing it, and scanning it again. That process was repeated with a second bone, and those 4 scans underwent the same deviation analysis. Shown here is the raw data of the experiment in millimeters. There are a few points to highlight out of these tables. First, a large average change indicates poor repeatability. This would indicate that there is a large amount of translational movement. In the table where translational motion was of interest, the values were relatively small and much smaller than our cutoff of half a millimeter. Second, large standard deviation of change suggests poor rotational stability. This is because in rotational motion, the average change could be close to 0 with points on opposite sides of the axis of rotation canceling each other in the average. The table used to demonstrate rotational stability also has relatively small values, with 0.353 millimeters being the largest, again under the half a millimeter cutoff. From this data, we can confirm that the new design satisfies all the requirements of the simulator. In fact, this new design has been implemented and successfully used to train residents at the University of Iowa on treating pediatric elbow fractures. This work was funded both by the Agency for Healthcare Research and Quality and the Pediatric Orthopedic Society of North America. Thank you for your attention.